Welcome all to the today's session. Today we will be discussing about management of gestational trophoblastic disease. That is the Green Top Guideline number 38. It is published in September 2020. We begin with our quote, Master MRCOG with concept-oriented clarity. This Green Top Guideline is going to be very important from Part 2 MRCOG point of view. There will be SBA as well as EMQs from this particular topic. Okay, so as I mentioned in my previous lectures, before every Green Top guideline, there is a summary, short summary of the guideline. This summary you have to read, and it is quick and it is easy to remember, easy to revise. Okay, but when you are reading for the first time, you have to read the full guideline. Okay, then you can, when you are reading, you should highlight the important things from the guideline and you can concentrate on those, but in revising always revise this summary completely. Okay, so what is the clinical presentation of gestational trophoblastic disease? The most common presentation is irregular vaginal bleeding, a positive UPT and supporting USG evidence. Okay, so early pregnancy with bleeding, positive USG, always think of this gestational trophoblastic disease. Less common presentation is hyperemesis, increased uterine enlargement, hyperthyroidism, early onset preeclampsia, and abdominal distension due to theca lutein cyst. And very rare presentation, it is mainly because of metastasis, and it may be in form of hemoptysis or seizures due to metastatic disease affecting the lungs or the brain. The definitive diagnosis of molar pregnancy is made by the histological examination only. Okay, so when we are talking about GTD, that is gestational trophoblastic disease, we require a histological confirmation. When we are talking about gestational trophoblastic neoplasia, we require a persistently rising beta SCG. Okay, not the histopathological confirmation. Just remember this, the diagnosis of GTD is by histopathological examination. Then coming to the treatment. Treatment for the this gestational trophoblastic disease is a suction curettage for complete mole as well as partial mole. Later on, we will discuss what exactly this gestational trophoblastic disease include. Okay, but in summary, you just remember when we are talking about the treatment, the choice of treatment will be the suction curettage, which is a method of choice for complete molar pregnancies. And if you have an option of ultrasound guided suction curettage, select that. Okay, ultrasound guidance during removal and curettage may be of use to minimize the chance of perforation and to ensure that as much as tissue is possibly removed. Okay, so ultrasound guided suction curettage is going to be the method of choice. Okay, it is important for both complete as well as partial mole. And what is the role of medical method, that also we'll see now. So method of choice for removal of partial molar pregnancy is suction curettage, except when the size of the fetal parts deters the use of suction curettage, and then medical removal can be used. Okay, so even for even for the partial mole, the suction curettage remains the method of termination, except when the size is big. Okay, but they have not specified how much size. Okay, then anti-D prophylaxis is recommended following the removal of molar pregnancy. Cervical preparation prior to the uterine removal is safe. Then oxytocin infusion during the surgical removal. What does the guideline talk about use of oxytocin either during or prior to the? So definitely prior to the use of prior to the suction curettage, prior to the procedure, the oxytocin infusion is not recommended. Okay. If there is a significant hemorrhage prior to or during the removal, surgical removal should be expedited and the need for oxytocin infusion weighed up against the risk of tissue embolization. So there is a risk of tissue embolization with the use of oxytocin. So as far as possible, avoid the use of oxytocin. Okay. Then guideline talks about repeat surgical removal. That means you have done the suction curettage, but there is a retained products of conception or retained tissue. Then what is to be done? When it is to be done? Okay. So repeat surgical removal, there is a role for urgent surgical management for women who is experiencing heavy or persistent vaginal bleeding causing acute hemodynamic compromise, particularly in presence of retained pregnancy tissue on ultrasound. So if you have already done the suction curettage, the patient is bleeding again, or there is a persistent bleeding, there is a role of repeat suction curettage. However, if there is acute hemodynamic compromise, you go for a repeat procedure. But if the patient is hemodynamically stable, what the guideline says, discuss the case with the relevant GTD referral. Okay, so outside the context of acute compromise, there should be consultation with the relevant GTD referral center before performing surgical management for the second time in the same pregnancy. So it will depend upon the hemodynamic status of the patient. So depending upon the hemodynamic status which is given in the scenario, you will select the option whether the GTD referral is to be done or whether the repeat suction curettage is to be done. Okay, this can be asked in the SBA or even in EMQ also. Then coming to the histopathological examination of pregnancy following miscarriages, because what to do in miscarriages, whether to send all the samples for histopathology or which samples are to be sent. If the fetal parts are not identified on ultrasound or during evacuation, then you send the pregnancy tissue for histology to exclude gestational trophoblastic disease. It applies to both miscarriage as well as abortion also. Okay, so if you have not identified the fetal parts at any stage of the pregnancy, either ultrasound or during evacuation, then you will send the products for products of conception for the histopathology. If fetal parts are identified, routine histology is not required. Okay, so women who receive care for miscarriage, they are to be followed up after miscarriage as well as medical abortion, and these women will have to do urine pregnancy test after 3 weeks. This urine pregnancy test should be negative. Okay, so women with an elevated beta hCG after a possible pregnancy event, they should be referred to GTD center. Okay, for persistently elevated hCG either after ectopic pregnancy has been excluded or after 2 consecutive treatments for methotrexate for pregnancy of unknown location. Suppose you are, even for ectopic pregnancy, you have to do the beta hCG post treatment, and those patients who are receiving the methotrexate for pregnancy of unknown location, even if you have given 2 methotrexate and still the beta hCG is positive, then you will refer these patients to the gestational GTD center. Okay, so any woman who develops persistent vaginal bleeding after pregnancy event is at risk of having GTN. An urine hCG test should be performed in all cases of persistent or irregular vaginal bleeding lasting more than 8 weeks after the pregnancy event. So any hCG elevation after 8 weeks, or the patient is presenting with persistent or uterine bleeding, you have to do this hCG test. Okay, so after the pregnancy event, the patient is having persistent bleeding or irregular vaginal bleeding after 8 weeks, you will do the beta hCG again. Okay, so symptoms from the metastatic disease such as dyspnea, hemostasis, or new onset of seizures or paralysis can occur very rarely. Biopsy of secondary deposits in the vagina can cause major hemorrhage and is not recommended. So biopsy, if there are metastatic deposits in the vagina, the biopsy is not recommended. Now the guideline talks about the uh, ectopic molar pregnancy in the ectopics. Okay, you have an ectopic pregnancy in which you are suspecting molar pregnancy, or the histopath has come like that, or the twin pregnancy where there is a possibility of the molar pregnancy. How to deal with this? Okay, so suspected ectopic molar pregnancy, manage as any other cause of ectopic pregnancy. If there is a local tissue diagnosis of ectopic molar pregnancy, the tissue should be sent to center with appropriate expertise for pathological review. Okay, so you have to send the tissue for expertise for the pathological review again. Okay, so twin pregnancy of a viable fetus and presumptive coexisting molar pregnancy. Okay, so you have a twin with viable fetus and suspected coexisting molar pregnancy. Okay, so combined molar pregnancy and viable twin, or where there is a diagnostic doubt whether you are dealing with a partial mole, that means you are having a fetus and the other is a partial mole. Okay, so or it is a partial mole, you require 2 referral. One is a fetal medicine center referral, and second is a GTD referral center. Okay, counsel for potential increased risk of parental morbidity and mortality of the outcome of GTN. So when you are given such a scenario and asked in the EMQ, look for 2 referrals. These patients will, they may give you different referrals, or they may consider the termination. This multiple options will be given, but these patients will be requiring 2 referrals. One is a fetal medicine reference and second is a GTD center. Okay, consider prenatal invasive testing for fetal karyotype in cases where it is unclear if the pregnancy is a complete mole with a coexisting normal twin, or it is a possible singleton partial molar pregnancy. So you cannot differentiate between the two. Then you have to do fetal karyotype. So fetal karyotype is required in these cases where you suspect that it is a twin pregnancy with one complete mole and one normal twin, or it is a singleton pregnancy with a partial mole. Okay, so pre-invasive testing for fetal karyotype should also be considered in cases where there is abnormal placenta, such as suspected mesenchymal hyperplasia of the placenta. So if you have a hyperplasia of the placenta or mesenchymal, because this is also SBA which has been asked in the past, they give you the describe the ultrasound picture, and they mention that the mesenchymal hyperplasia of the placenta is suspected. So in these cases, fetal karyotype is the test of choice, okay, for evaluation. Then placental site trophoblastic tumor or epithelial trophoblastic tumor management. All women with placental site trophoblastic tumor, that is PSTT, or ETT, that is epithelial trophoblastic tumor, to be registered with and cared for within the GTD center. So PSTT and ETT will also be registered with the GTD center. So we should know which cases require GTD referral. Okay. So that also we'll see in this slide. Before that, we'll discuss about the placental site nodule. Okay, there are two types of placental site nodule. One is a typical and one is atypical. We will not go much into the histopathology, but the typical PSN do not currently require further investigation or review from practical point of view. But atypical PSN, that is atypical placental site nodule, histology to be reviewed centrally. All women with atypical placental site nodule will then be called up for central review to discuss the existing data and perform staging investigation and to determine further management. So a typical PSN definitely requires GTD referral. Okay, typical PSN does not require further investigation or review. Okay, then which patients are to be referred to the GTD center? All women diagnosed with gestational trophoblastic disease, such as complete molar pregnancy or partial molar pregnancy, twin pregnancy with complete or partial molar pregnancy, limited macroscopic or microscopic molar change suggesting possible early complete or partial molar pregnancy or choriocarcinoma, then PSTT or ETT, and atypical PSN. So all this spectrum of GTD needs this referral to the GTD center. They have not mentioned about the typical PSN, but they have specifically mentioned about the atypical PSN. So there may be SBA which patients may not require referral, then the answer could be the typical PSN. Okay. Now the guideline talks about the follow-up, and here the SBAs are more frequently asked. Okay. So what is the optimum follow-up for the diagnosis of gestational trophoblastic disease? Complete molar pregnancy. If it is a complete molar pregnancy, you have the treatment of choice is a suction evacuation. Post suction evacuation, we are going to monitor these patients on SCG. So if SCG has reverted to normal within 56 days of the pregnancy event, then follow-up will be for 6 months from the date of uterine removal or suction curettage. Okay. If the SCG has not reverted to normal within 56 days of the pregnancy event, then the follow-up will be for 6 months from the normalization of the SCG level. So what exactly this particular thing means, that the suction curettage is the treatment of choice. Post suction curettage, you will monitor the beta SCG of these patients and see when it comes to the normal. If it comes to the normal within 56 days or up to 56 days, then the follow-up is for 6 months from the date of suction evacuation. If the beta SCG has come to normal after 56 days, then the follow-up will be for the 6 months from the normalization of the SCG level. This is the difference between the two. When does this follow-up ends? Okay. So for complete molar pregnancy, evacuation is done, SCG monitoring is done. If it comes to normal up to 56 days, that follow-up is for 6 months from the uterine evacuation. If it is after 56 days, then the follow-up is for 6 months from the SCG normalization. Okay. So from the date when the SCG has become normal, after that you will follow up these patients for 6 more months. Okay. This difference you have to remember because this is a SBA, frequently asked SBA. Then what is the follow-up for partial molar pregnancy? In partial molar pregnancy, you should follow up these patients with SCG, and once you get two normal SCG levels at 4 weeks apart, then the follow-up is concluded. So it is a relatively simple follow-up for partial molar pregnancy. You should get 2 samples negative at 4 weeks apart. So you will follow up these patients on beta hCG. Once the sample comes normal, another beta hCG after 4 weeks. If that is normal, then the partial molar pregnancy follow-up ends. Okay. So this follow-up is also a single based answer question. Now coming to the treatment for GTN. Women with GTN may be treated with single agent or multi-agent chemotherapy. Treatment used is based on FIGO 2000 scoring system for GTN. So when it comes to the GTN, we know that GTN does not require histopathological diagnosis. GTN is a persistent beta hCG elevation following a pregnancy event or previous treatment of GTD. And these patients you need to score by the FIGO 2000 scoring system. Okay. Then what about these patients are given this chemotherapy as per this FIGO 2000 scoring system, except PSTT and ETT. They are now recognized as a variant of GTN. They may be treated with surgery because they are less sensitive to chemotherapy. So we have seen who all are requires the GTD referral, out of which these PSTT and ETT and even atypical placental site nodules, they require surgical treatment and they are less sensitive to chemotherapy. Okay. So GTN chemotherapy, this is dependent on the FIGO 2000 scoring system. It is divided. Patients are divided into two groups: low risk and the high risk. Low risk is up to 6. When the this score is 6 or less, then they are considered as a low risk patients and they are given single agent chemotherapy with methotrexate. If the score is 7 or more, they are considered as high risk and they are given multi agent chemotherapy, that is EMACO regimen. Then what about PSCT and ETT? I have just mentioned they are less chemosensitive, so primary treatment is a surgery. Then the guideline talks about if there is a conception following complete or partial molar pregnancy, monitoring of women following successful pregnancy after previous molar pregnancy and outcome of subsequent pregnancies. Women are advised not to conceive until their follow-up is complete. Women who undergo chemotherapy are advised not to conceive for 1 year after completion of treatment. So if the woman has taken the treatment for gestational trophoblastic, either in form complete or partial, they should complete their follow-up first. Okay, that is the most important thing. Before conceiving, they should complete their follow-up first. If she has received the chemotherapy, okay, then they are supposed to avoid the pregnancy for 1 year. Okay, so this is the important thing about avoiding the conception after the treatment for the molar pregnancy. Okay, now previous molar or complete molar pregnancy, avoid conception until follow-up is completed. If she has received chemotherapy, avoid conception for 1 year after completion of the treatment. Okay. Then after successful pregnancy, post-mol. So post-mol, if she becomes pregnant, she will have a routine obstetric care, early ultrasound and reassurance. Okay. So what is the treatment? The treatment does not differ if she becomes pregnant following the treatment of vesicular mole or the hydatidform mole. Okay, it is a routine obstetric care. So in subsequent pregnancy following previous molar pregnancy which has not required treatment for GTN, do not send the post-pregnancy hCG sample. Histological examination of the placental tissue from any normal pregnancy after a molar pregnancy is not indicated. So in the subsequent pregnancy, you don't have to follow that pregnancy with beta hCG. No need of sending the placenta for the histopathological tissue examination if it is a second or successful pregnancy following previous molar pregnancy. Okay, so this also you should remember. Okay, then long-term outcome. So suppose you have treated these patients by suction curettage, few patients may require this GTN will be requiring chemotherapy. So what is the long-term outcome of women who are treated for GTN? So most patients require chemotherapy. So excellent with the long-term outcome is excellent with overall cure rate is up to 100%. Pregnancy rate is 80% following treatment for GTN with either methotrexate alone or multi-agent chemotherapy. Risk for premature menopause for women treated with combination agent chemotherapy. So if the patient requires multiple chemotherapy agents or combination chemotherapy, then these patients are at high risk for development for the premature menopause. And if they are approaching age of 40, then their fertility is reduced. So you have to explain to these ladies two things. One, they are at risk of premature menopause, and second, the fertility is reduced after the age of 40 in these patients, especially those who receive the combination chemotherapy. Okay, so the same thing is explained here. So combination or higher dose chemotherapy, patient is at risk of increased risk of premature menopause. Women more than 40 years, we need to warn them about reduced fertility and greater risk with high dose regimens. Then guideline talks about the contraception. Again, contraception is going to be very, very important for these patients. So contraception following treatment for GTD, it is safety and timings, not to become pregnant until they have completed their follow-up. This we have already discussed. The use of exogenous estrogens and other fertility drugs may be used once HCG levels have returned to normal. So once the HCG comes back to normal, the exogenous estrogens and other fertility drugs can be used. Hormone replacement therapy may be used once the HCG levels have returned to normal, and online support groups are available. That is molarpregnancy.co.uk alongside regular drop-in support groups at the respective GTD centers. Okay, so here in the GTD guideline, the GTG, they have mentioned hormone replacement therapy may be used once the HCG levels have returned to normal. Okay, and use of exogenous estrogen and other fertility drugs may be used once the HCG levels have returned to the normal. Okay, but the FSRH guidelines specific to the contraception that we will see in the subsequent slides. Okay, what does the FSRH, okay, guidelines say about the contraception? So how long should a woman wait after GTD before trying to conceive? After complete molar pregnancy, women should avoid the subsequent pregnancy for at least 6 months to allow HCG monitoring for the ongoing GTG. So this we have discussed that the patient will follow up the beta HCG, and once it comes to normal, then she can conceive. Okay. Now, after partial molar pregnancy, women should be advised to avoid the pregnancy until 2 consecutive monthly HCG levels are normal. That means in both cases, the HCG level should come back to normal. The follow-up also partial and complete we have already seen. Women who have received the chemotherapy for GTD should be advised to avoid the pregnancy for 1 year after the treatment is complete. So if she has received the chemotherapy, then it is a 1 year. If it is a partial molar pregnancy, then she should wait till the HCG becomes normal. That is, till you get a 2 beta HCGs negative at 4 weeks apart. If it is a complete molar pregnancy, we have seen you have to follow up these patients, and depending upon the timing when the beta HCG comes normal, the follow-up will conclude. That it will conclude at 6 months from the suction evacuation if the beta HCG is normal within 56 days. If the beta HCG is coming to normal after 56 days, then the follow-up will conclude 6 months after the normalization of the beta HCG. Okay, and after that she can try for the pregnancy. This is what the FSRH guideline says, whatever has mentioned in the GTD GTG. Okay, same. Then which contraceptive methods are safe to use after the GTD? There can be a question either from FSRH or from the GTD regarding the contraceptive methods. So women should be advised that most methods of contraception can be safely used after the GTD and can be started immediately after uterine evacuation, with exception to intrauterine contraception. So IUCDs are contraindicated immediately after GTD treatment. IUC should not be inserted in women with persistently elevated HCG levels or malignant disease, and IUC should not normally inserted until the HCG levels.
This is a reminder. Priyadarshini, revise your today's study.
Alexa, stop.
This is a reminder.
Alexa, stop.
Priyadarshini, revise your today's study.
So which methods are safe to use after GTD? Women should be advised that most methods of contraception can be safely used after the treatment for GTD and can be started immediately after uterine evacuation, with the exception to the intrauterine contraception. So IUCDs are not recommended after the GTD treatment. IUC should normally be inserted and should not be inserted until beta HCG levels have normalized, but may be considered on a specialist advice with the insertion in a specialist setting for a woman with decreased HCG levels following discussion with the GTD center. So if the patient is insisting, then what we may think of this, with the specialist advice, and along with the discussion with the GTD center in specialist setting, it may be considered. Okay, but otherwise routinely not recommended. Then what about emergency contraception? Emergency contraception is indicated if there is unprotected sexual intercourse takes place from the 5 days after the treatment for the GTD. So you can give the emergency contraception. Then which emergency contraceptive should we use? Women should be advised that the use of oral EC is safe. So here you can give oral EC, that is hormonal ECs can be given. Insertion of copper IUDs for EC may be considered in a specialist setting for women with decreasing SCG levels following discussion with the GTD center. Okay, so EC is preferably oral EC. Okay, insertion of copper IUD for EC may be considered in a specialist setting for women with decreasing SCG levels following discussion. This is what the guidelines says. Then what about the hormonal contraception? Hormonal contraception can be started immediately after evacuation for GTD. This is what the FSRH guidelines says. Then female sterilization is safe option for permanent contraception after GTD. Okay. So this is what is the guideline says about the contraception. So this was the summary. Now we will go into the details of the guideline. So gestational trophoblastic disease, what exactly it includes? So it includes the group of disorders spanning from pre-malignant conditions of complete or partial molar pregnancies, also known as hydatidiform moles, through to the malignant conditions such as invasive mole, choriocarcinoma, and very late placental site trophoblastic tumor and epithelioid trophoblastic tumor. So it includes everything from complete molar pregnancy, partial molar pregnancy, invasive mole, choriocarcinoma, and PSTT and ETT. So this is what is the spectrum of GTD, and the malignant potential of atypical placental site nodules remains unclear. Okay. So if there is any evidence of persistence of GTD after primary treatment, most commonly defined as a persistent elevation of the SCG, the condition is referred as a GTN. Okay. So this is what is the difference between the GTD and GTN. So persistent elevation is the hallmark for the development of the GTN after the primary treatment of GTD. Okay, so the diagnosis of GTN does not require histopathological confirmation. This we have discussed in the summary. The diagnosis of complete, partial, atypical, and PSTT and ETT does not require histopathological confirmation. Does require histopathological. So when we are talking about GTD, we require histopathological confirmation. Okay. So prevalence, there can be SBA on this. Prevalence and risk factors for GTD. Overall prevalence is around 1 in 714 live births. Okay. As far as Asian women are concerned, it is little higher, 1 in 387. And non-Asian women, it is 1 in 752. Okay. So they may ask you either of this particular figure and generally in numericals, you should make a list of the numerical answers at the back of your notebook. All numericals you include. Okay, you write the name of the guideline and you write the numericals together. Okay, so Asian women, they are at higher risk, 1 is to 387, and non-Asian women is around 1 is to 750. Sometimes they can ask you about the age related prevalence, because it is common at extremes of age. In that also, higher the age, that means after 50 years it is more common. 1 in 8 pregnancies there can be GTD, and age at conception at younger age below 15 years it is 1 in 500. Okay, so at extremes of age you have higher incidence. Okay, now also very frequently asked question is about the this either genetic makeup or of the molar pregnancy, that is complete molar and partial molar. That is also very frequently asked. So let us see the difference between the complete mole and the partial mole. Complete mole is a diploid. It is androgenic in origin. There is no evidence of fetal tissue, and the mechanism of formation of complete mole is androgenesis, where there is a empty ovum which is fertilized by single sperm which gets duplicated. Okay, so that happens in 75 to 80% of cases. The phenomena is known as androgenesis, and in some cases complete moles, in 20 to 25% cases, can arise from dispermic fertilization of empty ovum. That means the ovum is empty and it is fertilized by the two sperms, but it is less common. Okay, so the genetic composition, most commonly it is 46XX. Okay, so the ovum is empty, there is no genetic material, and there is a 23X sperm which is fertilizing and it gets duplicated forming 46XX. This is what is the commonest. Okay, but in 20-25% cases it can be dispermic fertilization of empty ovum. Okay, what happens in partial mole? It is triploid in nature. In 90% of cases it is triploid. In almost all cases following dispermic fertilization of an empty on a normal ovum. Okay, so here there will be 23x ovum which will be fertilized by the two sperms. Okay, so evidence of fetal tissue is there, or RBCs are there, and two sets of paternal haploid chromosomes and one set of maternal haploid chromosome is there. Okay, so this leads to the partial mole which is diploid in nature. Complete mole is diploid in nature. So what is the genetic makeup in complete mole? It is 46XX. Original nuclear DNA comes from the father only. Okay, the egg has no maternal genome. It is an empty ovum and it is fertilized by one sperm that duplicates itself, and most common is a 46XX or two sperms. Okay, that is less common. So less common is a 46XY, more common is a 46XX. Okay, in partial mole it is triploid in nature. Okay, 69 chromosomes. Okay, so origin is a normal ovum with maternal DNA which is fertilized by the two sperm. So extra paternal set of chromosome is there. So it is a diandritic triploid. So the chromosomal composition may be 69XXY, 69XXX, and 69XYY. Okay, so this can be the chromosomal composition. Generally, they ask you SB on this regarding the composition of genetic composition of the complete or the partial. Okay. Now, GTN may develop after a molar pregnancy, a non-molar pregnancy, or a live birth. Okay, so it may be after the molar pregnancy or normal pregnancy or live birth. The incidence after a live birth is estimated to be very, very rare. It is 1 in 50,000 cases. After the live birth, it is very less. Okay, so vaginal bleeding, we have seen that is the commonest presentation for molar pregnancy almost in 60% of cases. Gestational age presentation is around 10 to 11. It is reduced now. Initially, it was 11 weeks, but it has come down to 10 weeks now. And this is mainly because of the use of ultrasound. And because of the ultrasound, we are able to diagnose now. The diagnosis rate is also increased from 1% to 12% over the period of time. Okay. So ultrasound features. What are the ultrasound features of molar pregnancy? That also we should know. In complete molar pregnancy, by around 5 to 7 weeks of gestation, you see a polypoid intrauterine mass. After 8 weeks, you will see the thickened cystic villi giving the snowstorm appearance. There will not be any gestation sac and there is no fetus. The UHG sensitivity is around 95%. Okay, so this kind of picture you will get. There is no fetal tissue and you will see this snowstorm appearance in cases of complete mole. Okay, so polypoidal uterine mass, thickened and cystic villi giving the snowstorm appearance. While in partial molar pregnancy, you will see the enlarged placenta with focal cystic changes and empty sac, or there can be delayed miscarriage also, and possibly non-viable fetal tissue. So along with the fetal tissue, you will see the focal placental changes. So you may see a fetus and the changes in the placenta. Okay, so the focal cystic change along with the fetal tissue you will see in partial mode. Okay, so this is what is the presentation or ultrasound picture in complete mole and the partial mole. So additional points in the diagnosis of molar pregnancy. So additional markers, especially for partial mole, this also they ask you, especially with the P57 markers, they'll ask you. Okay. So there will be multiple soft markers, cystic spaces in the placenta, gestational sac shape. The transfers to AP dimension ratio is more than 1 is to 1.5. This is more common with the partial mole. Okay. So if you see this gestational sac ratio, if they have given, then your diagnosis will be partial mole. Again, they can ask you this in the SBA. Okay. And as far as P57 markers are concerned, P57 negative is a complete mole, while P57 positive is a partial mole. It is positive in P57. It is positive in partial mole, P57 positivity. So definitive diagnosis is by histopathology, differentiation of the partial versus complete mole. In complete mole, there will be absence of the fetal tissue, extensive hydropic change to the villi, and there is excess trophoblastic proliferation. While in partial mole, there is a presence of fetal tissue, focal hydropic change to the villi, and some excess trophoblastic proliferation. While here it is extensive trophoblastic proliferation. And immunohistochemistry, because P57 is a paternally imprinted gene but maternally expressed. That is why in complete mole it is P57 negative, because ovum is empty. That is why there is no maternal expression of the paternal gene. While in partial mole there is a ovum with a 23X, and this paternally imprinted gene gets expressed. That is why in partial mole P57 positivity you get. Okay, so this is SBA, which is frequently asked about the P57 immunohistochemistry. Okay, so complete molar pregnancies are not associated with the fetal parts, and therefore suction removal is the method of choice for uterine removal irrespective of the uterine size. Medical removal of a complete molar pregnancy should be avoided if possible, irrespective of the agent's use. So irrespective of the size, in cases of complete mole, the suction evacuation is the mode of choice. They may give you the size of the uterus 24, 26 weeks, but if it is a complete mole, suction evacuation is the method of choice for the complete mole. Risk of developing GTN and requiring chemotherapy is 16-fold higher with medical methods than the surgery. That is why, because if you go for medical methods, the risk of treatment for GTN is 16-fold higher. Okay. So theoretical concern, which is supported by the clinical evidence, is that avoid use of oxytocic agents because potential to embolize and disseminate trophoblast. So when you are doing the suction removal, as far as possible, avoid oxytocic agents. Okay, because there can be embolization and dissemination of the trophoblastic tissue through the venous system, leading to the ARDS, similar in presentation to the amniotic fluid embolism. Okay. So twin pregnancies where there is a non-molar pregnancy alongside a molar pregnancy, and the woman has decided to terminate pregnancy, or there has a demise of coexisting twin and the size of the fetal part deters the use of suction evacuation, medical removal can be used. So primary method is the suction curettage. However, if it is a twin pregnancy where there is a non-molar pregnancy alongside a molar pregnancy, in that particular case, you may think of the medical removal. Okay. So there is a higher rate of incomplete removal when you go for the medical methods, and the risk of this increasing the need for treatment of GTN is 13 to 16% with complete molar pregnancies and 0.5 to 1% with the partial molar pregnancy. So following complete molar pregnancy, the risk of GTN is 13 to 16% and 0.5 to 1% following partial molar pregnancy. Okay. Now, what about the anti-D? Now we have seen the method of treatment is a surgical removal. Okay. Uh, but what about the anti-D? What does the guideline say? Again, here the either SBA or EMQ can be asked. Mostly SBA question can be asked. In complete molar pregnancy, chorionic villi are poorly vascularized. So trophoblast lacks the D antigen. So what theoretically speaking, anti-D is not required because trophoblast is lacking D antigen. This is what is theoretically happening. Okay. And in partial pregnancy, there is a fetal tissue. So the D antigen is present. So anti-D is required. Okay. So this is what is the theoretical situation in complete as well as partial mole. But what is the practical point? The diagnosis of the partial or complete mole is by the histopathology only. So if the diagnosis is not confirmed by the histopathology within 72 hours, then we need to give anti-D prophylaxis. So when you are asked about the management, when you are asked about the anti-D, you read the scenario carefully, whether the histopathology report has been given and it has confirmed the diagnosis of complete molar pregnancy or the partial molar pregnancy. If it is a partial molar pregnancy, then definitely it is required. If it is a complete molar pregnancy, which is proved by histopathology, then it is not required. But if the most of the time histopathology report is not available within 72 hours, that is why we need to give the anti-D practically. Okay. Now, the guideline talks about the repeat surgical removal in the same pregnancy. Okay. So, indication is a persistent heavy bleeding and retained tissue on ultrasound after initial evacuation. This in the summary I have already mentioned. When there is a persistent heavy bleeding or there is a retained tissue on ultrasonography, first what we will see, what is the hemodynamic status. If it is an emergency situation where there is a hemodynamic instability, we'll go for immediate surgical management. Okay. Then other fertility preserving measures in such cases are, you can go ahead with the balloon tamponade, you can think about uterine artery embolization, and vaginal metastasis. If they are bleeding, then you go for vaginal packing for compression. Okay. So if there is no fetal compromise, so outside the context of acute fetal compromise, there should be consultation with the relevant GTD center before performing surgical management for the second time in the same pregnancy. This also we have discussed in the summary. If there is no fetal compromise, discuss the case with the GTD referral center. Okay. Now the guideline will talk about the twin pregnancy of a viable fetus and presumptive coexistent molar pregnancy. These patients will require immediate referral. I have already mentioned two referrals will be required: regional fetal medicine referral and GTD specialist center. Okay. In such cases, there is a high chance of fetal loss to the extent of 40%, 36% chance of preterm birth, and preeclampsia risk gets double, that is 20%. Okay. So preeclampsia risk is 20%, fetal loss 40%, and preterm risk is 1 in 3, that is 36%, 35-36%. Okay. Now coming to the PSTT and ETT management. For PSTT and ETT, you have to refer these patients and ask them to register with the GTD center. Disease behavior, it is different and less predictable than other gestational trophoblastic neoplasia, and primary treatment is hysterectomy. Okay. So if the disease is localized, then go for surgical treatment. Okay. And if the disease is advanced, in that particular case, long interval since the index pregnancy or there are extensive metastases, in that case, intensive chemotherapy can be given. Okay. Otherwise, when the disease is localized, in cases of PSTT and ETT, you go for hysterectomy. Okay. This PSTT and ECT are less chemo sensitive. Okay. So the same key points are explained here. These are rarest of GTN. 0.2% of all GTD are PSTT and ETT. Biological behavior, generally these have a low SCG production. They are confined to the uterus for a longer time. Lymphatic spread is common, and they are more chemo resistant. Okay. So management principle, they are not managed by the FIGO scoring. Prognosis is in prognosis, the important factor is the interval since the positive pregnancy. Okay. So in PSTT and ETT, it is the interval since the positive pregnancy. If it is after 48, if it is diagnosed after 48 months of the pregnancy, then the prognosis is very, very poor. There is a 100% mortality, and even with intensive therapy, more than 50% there is a mortality. But if it is diagnosed within 48 hours of the pregnancy event, then there is a good prognosis. There is a long-term survival in these particular cases. Other poor prognostic factor is the stage 4 disease. Risk in future pregnancy, there is a recurrent risk of 1% of PSTT and ETT. However, overall incidence of the PSTT and ETT is less. They are contributing only 0.2% of all GTDs. Okay. And the recurrent risk is 1%, higher after complete mole than the partial mole. This is about the overall, not only the PSTT and ETT. This recurrent risk of the GTD, it is higher after complete than the partial mole. Okay. So they can ask you the recurrent risk of the GTD. Okay. It is 1%. Okay. Now the guideline talks about the placental site nodule. Okay. We have seen there are two. One is a typical placental site nodule and another is a atypical placental site nodule. Okay. So placental site nodule, which is typical, generally it is benign, minimal clinical significance. If it is a atypical placental site nodule, it can be associated with the PSTT or ETT. The risk of progression to the malignancy is to the tune of 10 to 15%. Clinical presentation, often it will present with abnormal vaginal bleeding. It is detected by endometrial biopsy or hysteroscopy. So key message is that atypical placental site nodule needs careful evaluation and follow-up. If the family is complete, go for hysterectomy. Okay. Only if no metastatic disease and desire for future fertility, careful counseling required with a further investigation and follow-up. So in PSTT, ETT, and atypical placental site nodule, the choice of treatment is a surgical treatment in form of hysterectomy. Okay. Now coming to the treatment for the GTN. This is the last part. Okay. So treatment of GTN. In the summary, we have mentioned that the treatment of GTN is based on the FIGO 2000 scoring system. This scoring system divides the patients into two risk categories. One is a low risk category and another is a high risk category. Okay, so if the score is less than or equal to 6, they are low risk. If it is 7 or more, they are high risk. Okay, low risk patients will require single agent chemotherapy with methotrexate and folinic acid, while if the score is 7 or more, they will require multi-agent chemotherapy, and it is an EMACO region. Okay, so the drugs are methotrexate, dactynomycin, etoposide, cyclophosphamide, and vincristine. Okay, so and you will have to follow up these patients with beta ICG till it becomes normal. Okay, choriocarcinoma will refer to the specialist center. It requires extensive evaluation. And if the score is very high, more than 13, these patients have the high risk of death within 4 weeks of the diagnosis, and bleeding into the organs is the cause for the death. Okay, risk of late death is because of the multi-drug resistant disease. Okay, so generally there is a EMQ which is asked on this. So this FIGO 2000 scoring system you should remember. Okay, so these are the points on which this scoring system is based, such as age, antecedent pregnancy, interval months from the end of the index pregnancy to the treatment, then pre-treatment serum beta ICG, largest tumor size including the uterus, size of the metastasis, number of the metastasis, and previous failed chemotherapy. And please remember the scoring. It is 0, 1, 2, and 4. There is no 3 score here. Okay, 0, 1, 2, and 4. See, they'll give you the long scenario, maybe 10 to 12 line there will be scenario. They'll give you the various investigations, the scan report, the X-ray report, and number of meds, etc. So you have to take into account each and everything. So you have to look for these parameters, then you calculate the score, then you decide whether it is a low risk patient or the high risk patient, and accordingly give either single agent or the multi agent. Okay, so that is why this particular slide is going to be very, very important, and this scoring system you should remember. It's easy to remember zero score because in a young patient following molar pregnancy, when the diagnosis is within 4 months and beta ICG is less than 1000, okay, it carries zero score. In these patients, the tumor size is less than 3 centimeter and the lung mets are also carrying zero score. Okay, so if there are lung mets, it will have zero score. Tumor size less than 3. Okay, beta ICG less than 1000. Diagnosis within 4 months. If it is molar pregnancy, age young patient less than 40, zero score. Okay, and obviously there are no metastasis in zero score. Okay, then comes the score 1, more than 40 or equal to 40. If it is following abortion, then interval from the end of the index pregnancy to the treatment. So if it is after 4 months up to 7 months or less than 7 months, in that case you will give 1 score. The beta ICG from 1000 to 10,000, less than 10,000. Remember, it is less than 10,000. 10,000 is here, 1000 is here. Okay, then largest tumor size less than 5, 3 but less than 5. The mets, spleen and kidney mets will have score of 1. Number of mets up to 4, 1 to 4 will carry the score 1. Okay, if the mets are 5 to 8, the score is 2, and if the mets are more than 8, score is 4. So this particular you have to remember, and you have to calculate the score. Okay, the cure rate for women with score of 6 or less is 100%, while the rate for women with score of 7 or greater is 94%. Okay, so pregnancy and long-term outcome for after molar pregnancy or GTN. So future pregnancy maternal risk, the maternal risk is not increased. Okay, there is no increase in the maternal complication. The pregnancy outcome, pregnancy immediately after vesicular mole, there is an increased risk of preterm birth, 25% chance. Pregnancy after an intervening birth. Okay, so after the vesicular mole, there is one pregnancy, and in the subsequent pregnancy, there is a risk of LGA baby and stillbirth risk is increased. Fertility after chemotherapy, chance of pregnancy is more than 80%. Similar after methotrexate or single agent chemotherapy. So fertility is good fertility after methotrexate as well as multi-agent chemotherapy. However, after the age of 40, you are going to counsel that patient, the chance of fertility will be reduced. Then menopause and fertility. Combination chemotherapy can lead to earlier menopause. So 13% will have the menopause by the age of 40, and one third, that is 36%, by the age of 45. So you have to counsel the women who are more than 40 years about the fertility impact. Now, previously this question has been asked, but I don't think they'll ask again. So GTG centers in the, which are the locations of the GTD center? There is a Charing Cross in London, Sheffield and Dundee. So these are the London, Sheffield and Dundee. At three places there is a GTD center. Emerging treatment, checkpoint immunotherapy with pembrolizumab for multi-relapse GTN. Okay. So this is a newer treatment. So that finishes the topic for today's discussion, that is gestational trophoblastic disease.
A 28-year-old woman undergoes medical management of a first trimester miscarriage at 9 weeks. On ultrasound prior to treatment, no fetal parts were identified. Product of conceptions are expelled completely. She is clinically stable. So, what is the next appropriate step? In this, she has expelled at 9 weeks. Product of conception are expelled, and an ultrasound, no fetal parts are identified. So, I don't think no further action is required. E.
Doctor, here medical management of a first trimester
Medical.
miscarriage
Okay,
at 9
okay,
months.
okay,
On
okay, okay.
ultrasound prior to the treatment, there were no fetal parts were identified.
Hmm.
Okay,
Hmm.
this is very, very important information.
Hmm.
It is a 9-week pregnancy. You are not identifying the fetal parts. Okay, so the options
Hmm.
are discard the pregnancy tissue without further investigation, send pregnancy tissue for histopathological examination, measure serum beta HCG weekly only, arrange repeat beta pelvic ultrasound in 2 weeks, and no further action is required. So this is the most important thing which we have discussed. I think you might have missed if you have not joined by that time. So you have to send the
Hmm.
pregnancy tissue for
Tissue
histological
for
examination.
histology exam.
What
Yes.
is the concept? In miscarriage or even in abortion, if the fetal parts are not identified on ultrasound or during the evacuation, you have to send the sample for histopathological examination. This is what is the concept. Okay. So when you will listen to my lecture, no, you
Hmm.
divide the lecture into various concepts, and then you can form your own scenario on that and look whether this your examination is based on completely on scenarios. Okay, so
Hmm.
these concepts will definitely help you. Okay, so when you read the question, look what exactly which they are checking, which concept they are checking. Okay,